Alcohol use disorder. Alcohol consumption is culturally accepted and widespread in Australian society, with approximately 80% of adults reporting alcohol use in the previous 12 months. However, alcohol use disorder can have devastating effects on individuals and their families. Unhealthy use of alcohol is one of our most common health problems, and it is linked to about 150,000 hospital admissions and 6,000 deaths per annum. What is alcohol addiction then? The National Institute on Alcohol Abuse and Alcoholism defines alcohol use disorder as a chronic relapsing brain disorder marked by an impaired ability to stop or control alcohol use despite adverse social, occupational, or health consequences. Two of the criteria are tolerance and withdrawal. Tolerance is needing to increase the amount of alcohol to achieve the desired effect or experiencing reduced effect from the same amount. Withdrawal is experiencing symptoms when not drinking or drinking to relieve withdrawal symptoms. Alcohol causes many behavioral issues. So when intoxicated, the level of risk depends on factors such as the amount of alcohol consumed, a person's body size, gender, levels of fitness, and their tolerance. Alcohol impairs judgment, coordination, and emotional regulation, increasing the likelihood of accidents, aggression, and risky behaviors. Individuals with alcohol use disorder who are also parents are at greater risk of negligence or being negligent to their children, thus triggering the involvement of child protection services. The children of alcohol users also have a greater risk and genetic predisposition of becoming alcohol user, of experiencing alcohol use disorder themselves. Women, 51% of women who have been victims of domestic violence and rape have reported that their perpetrator at the time of the crime was under the influence of alcohol. Lastly, the risk to self. The highest incidence of ambulance call-outs in Australia today involve alcohol use. Alcohol has a high burden of illness in Australia, including cardiovascular disease, cancers, and brain injuries. So, what are we doing what are we doing about alcohol today? So, tools that are currently used for screening and assessment. So recognizing the severe presentation of unhealthy alcohol use is relatively straightforward. Screening for alcohol is essential to identify low to moderate alcohol users. The Audit C stands for Alcohol Use Disorder Identification Test Consumption. It's a tool designed specifically for alcohol screening. It consists of 3 screening questions for alcohol use disorder. If a risk is identified during this brief test, then a clinician can proceed to the full audit, which is a questionnaire of about 10 questions. If further interventions are required, then the next step then should really be, once the audit has been completed, that a clinician recommends a full assessment. ASSIST is another tool, stands for Alcohol, Smoking, and Substance Involvement Screening Test. ASSIST is completed somewhere between 5 and 10 minutes. It generates a score based on the answers provided by the consumer, and the results are then shared between the interviewer and the consumer. It's followed by a brief intervention based on motivational interviewing using the states for change. For individuals with low to no alcohol use, education is provided to prevent alcohol use and increase an understanding of the harm. Assessment is a lengthy process that takes place after screening, and it involves collecting a full history of alcohol use and conducting a psychosocial assessment of the consumer and their circumstances. It elicits needs, including needs, risks, and strengths present in a person's life. Once a person has gone through the process of screening and withdrawal, and if they decide to proceed, then we'll enter in the alcohol withdrawal stage assessment. So individuals undergoing withdrawal may display agitation, disorientation, or aggression, which requires medical and nursing supervision. Consumers with significant levels of addiction require planning and support before they start to experience withdrawal symptoms. So we now move to the stages and symptoms present in alcohol withdrawal, including the severity, which is important for safe clinical management. So in minor withdrawal onset, we should expect the following. Should start roughly about 6 hours since the last drink. It can last between 24 and 48 hours. It includes tremors, sweating, headaches, gastrointestinal upset, anxiety, tachycardia, but the consumer will stay alert throughout this process. CIWA is the Clinical Institute Withdrawal Assessment for Alcohol. This is a tool used to assess and monitor withdrawal severity. In the case of the CIWA for consumers with minor withdrawal symptoms, the CIWA would then be below 10. Moderate to severe withdrawal symptoms. So here we'll start to look at more significant symptoms such as alcoholic hallucinations, the onset being between 24 to 6 days after the last drink, and the symptoms consisting of visual, tactile, or auditory hallucination. The consumer should expect to remain alert and orientated. So we'll then move to the second stage of moderate to severe withdrawal. This can occur between 6 to 48 hours since the last drink. It includes seizures. Seizures tend to occur more than once. Here we're referencing one episode within 6 hours, 1 to 6 episodes within 6 hours. Seizures pose a high risk of progression to delirium tremens, therefore requires medical and potentially nursing supervision to ensure the safety of consumers going through this difficult process on their bodies and brains. So the next step, we look at delirium tremens. This is for consumers presenting with severe symptoms of alcohol. Delirium tremens, despite being known to most consumers, it's actually a very serious medical condition with onset between 48 to 72 hours, and symptoms varying from tremors, sweating, severe anxiety, hallucinations and delusions, disorientation, and agitation. The withdrawal score here being really high, above 20. Delirium tremens is a serious medical condition with high risks of death if left untreated. So it requires significant consideration as to where a person with risk of the DTs or withdrawal seizures will take place. A hospital environment is essentially the best and most appropriate potentially place for entering in the withdrawal period, so that consumers can receive the adequate care and escalation in care where required. We now move on to the evidence-based intervention for alcohol dependence. So the psychosocial therapy, CBT, is the most recommended, being in the first line of care for alcohol dependence. It targets thoughts, feelings, and situations that trigger drinking, usually delivered in 12 weekly sessions. Works best when combined with medication and other therapies, given the challenges experiencing for someone who has been a moderate to severe user of alcohol. Motivational interview, being another type of intervention, helps explore and resolve ambivalence about change meaning moving towards sobriety. Best for mild to moderate dependence, useful for engaging people in the early stages of recovery. The next stage, another intervention, important intervention, is medical management through the use of benzodiazepines, more commonly and best known, diazepam, known as Valium as well. So it safely manages withdrawal symptoms and prevents complications. Diazepam helps reduce the risk of seizures and delirium tremens, typically uses for up to 5 days under supervision. It can be extended to 12 days if needed. The combined approach for best outcomes in the evidence-based interventions is really psychosocial therapy, supervised medications, Valium, for safer withdrawals. It encourages lower relapse risks and provides better recovery. The guidelines used here were written by Heber, and also the guidelines used by produced by Turning Point. One last item in the scope of alcohol use disorder is worth discussing is stigma. The World Health Organization recognizes stigma as a major issue across all mental health disorders. An interesting study written by So and colleagues identifies people with alcohol use disorder often face more discrimination than those with severe mental health illnesses, such as schizophrenia. And healthcare workers are vastly prejudiced against people living with alcohol use disorders. Haber and colleagues suggest that structural and organizational change have a very important role at addressing stigma, as is potentially the biggest catalyst for change in the behavior of healthcare providers. So what should be doing in practice to address stigma? Use person-centered non-judgmental care, integrate trauma-informed practice and be mindful of always using non-stigmatizing language. We should also be looking to, as far as structural and organizational interventions, we should be considering supervision to prevent burnout of staff providing interventions to people living with alcohol use disorder, and also encourage and promote self-care to reduce the risk of burnout and negative attitudes towards people living and working towards sobriety. Language matter. Language matter. Thank you for listening to me today. This was a presentation on alcohol use disorder.